you know, like cost mechanism in hospital is really challenging. So when we talk about the cost mechanism in hospital, we, you know, with the modern day hospitals with equipped with fantastic technologies, with you know, best of the art scientific systems and all this. So it is really challenging that, and all these departments in a hospital have different requirements. They use different machineries, the, you know, the charges of different, the fees of the different, remuneration of different doctors are different, the cost of the medicines are different, the number of hospital stay are different. Now the production or the cost in a hospital is measured these days average length of stay in a hospital. That is again to mention, this is especially when we discuss about the IPD, inpatient department, where the hospitalization is required. OPD, outpatient department, hospitalization is not required. So the average length of stay is utilized, length of stay, that is stay in the hospital, in the bed, OLOS, is utilized to understand that how many, you know, what is the production of this hospital for a particular patient, that is the length of stay. So when it is that complicated, I will discuss about few basic cost structures or cost mechanisms in hospital. But when we are looking at the measurement of this average length of stay or a cost associated with the length of stay, or treating a particular patient having a particular disease, or eventually when I talk about a hospital holistically, we don't talk about a particular disease, it's everything together, and there comes the challenge. When we talk about the everything together, the objectives of a costing system talks about number one, utilization of resources as you know, the number of average length of stay in oncology department may be much more than in a, you know, say orthopedics department or the cardiology, you know, so, and or say ophthalmology. So every particular department has varying or highly varying length of stay or utilization of different resources. The ophthalmology department or the neurology department have different utilization of MRI or X-ray from this oncology or say orthopedics or say pediatric department. Yeah. The next is 2, where we talk about profitability analysis department wise profitability analysis. Yes, and then when we do department specific profitability analysis, we need to understand in which department how much how much of the system being utilized, what is the patient footfall, what is the length of stay, what is the basic treatments generally sought for, all these things. Number 3 is fixation of doctors' remuneration. Often very challenging, and you do it based on the reputation of the doctor, the business a doctor is bringing, because nowadays in a corporate hospital doctors are consultant, and you know, doctors are seen as a profit making agent, and then the doctor's remuneration is highly dependent upon the profit they are able to generate. Therefore, fixation of doctors' remuneration is dependent upon, and it's also, you know, falls under an objective of the costing estimation in a hospital. The 4 is fixing schedule of charges. This is for each different services, how much do you charge to the patients for MRI, for X-ray, for 1 day stay in the hospital in the inpatient department, for utilization of OT. This is based on what kind of technology you have, what kind of services you are providing, what kind of buildings you have, what kind of TV you are providing, how many patients are sharing one particular room, and all these things, what kind of bed you have given to the patient. So everything determines the fixation of charges. Now this bed, the TV, the general equipments do not vary from the patient to patient, from the surgery to surgery, from the department to department. What varies are again the treatment specific utilization. So everything needs to be together when you estimate a cost, and based on that cost you estimate how much you are going to charge that patient. Number 5 is monitoring of factors affecting pricing. Monitoring of factors affecting pricing. Once a very senior hospital administrator told me a story that in a hospital it was being observed that in a particular bed whoever is coming is choking to death. They found that the oxygen cylinder, the ventilator, everything is fine, every equipment is working fine. But what used to happen, they never could figure out for a longer duration of time, for a considerable period of time. Eventually, when they figured out, the reason was whenever the maid used to come to clean that hospital, that particular room or near that particular bed, she used to remove that ventilator plug point from the charge, and then the patient died. So these are there are nurses who are just given charge to look at her wards or monitor around that where there is any mistakes or any lacuna in terms of the facility. If there is any leakage, or if there is water on the floor, if there is any seepage, if there is a probability of a short circuit, so she just looks around. So these are the monitoring of factors affecting pricing, because if there are fallacies on these parts, the cost will increase, and then the cost of a death is tremendous in a hospital. They cannot afford that, because it does not only spoil their business, it spoil their reputation for over a longer period of time. So they cannot afford that. Eventually, in a hospital, when we do the costing, we take into account both the direct cost and indirect cost. So the direct cost is basically the costs associated to the treatment, and then the indirect costs are those which are like say administrative costs, the building costs, the ambulance costs, which are basically similar for all these patients. So this direct cost and indirect cost, when taken together, we call it, one is absorption costing while costing, absorption costing, which is also known as account cost. This absorption costing takes into account both fixed cost as well as variable cost. And the second is marginal costing, which takes care of this variable cost only, because fixed cost remaining same, the variable cost with 1 unit of extra patient, what is my cost increasing? So we have to take both this absorption costing and marginal costing. And when we are doing this absorption costing and marginal costing, whichever mechanism we are following, we must understand that we are taking into account all these factors which are affecting costs in a hospital. So indirect cost, whichever factor needs to come, and in indirect costs, whichever factors need to come, and also the expenses, say stationary expenses, basic general expenses, we also need to account for them, like say stationary expenses, building capital value, the rent, the electricity, the equipment and machinery rent, the charges, we take care all of these, and therefore when we take into account all of these, then we estimate the cost for for every patient for a particular taking a particular treatment. Otherwise, we are certainly ending up in a miscalculation or misappropriation of a problem of a hospital cost. Now, when we talk about this hospital cost, we need to keep in mind, apart from these 5 points, that utilization of resource, department wise, profitability analysis, fixation of doctors, so on and so forth, we also need to find that which is the final product. So define the final product. What is my final product? Yes, and because we are accountable to the patients, we have to say, because of this particular treatment or this particular outcome, this particular process, we are charging you this. So what is the final product? Why we are following a particular process for a particular treatment? We are accountable, we are answerable to them. Number 2 is define cost centers, that which are different cost elements, which are different cost centers, which is raising my cost or which is contributing to my total cost. The third is assign inputs to cost centers, assign inputs. So which are the hospital inputs for that, for those particular cost centers, and how those inputs are contributing to the total cost or average cost or even marginal cost for those particular cost centers. Maybe for OPD my cost centers are different than my operation theatre, they are different from my ICU, they are different from my, say, an awareness generation camp or an outreach camp done by the hospital, say some eye checkup or some diabetic checkup, some cardiovascular or say some basic health checkup done in a particular camp. Say Apollo once or Narayana Rudalaya once decided to do these camps in one of their clinics. Yes, and if they can, why they do this? That's the primary one thing, is that to reach the patient. And the another thing is that because they have multiple selling points for multiple products, they don't only these days give this treatment. They are not only treating the patients but also selling medicines, also having diagnostic centers, also having small clinics. NH has started having small centers where they are treating that cardiology patients, very small centers, 5-bedded, 10-bedded, 15-bedded hospitals, where they are taking the emergency cases. They have all the facilities needed for a cardiovascular patient or a patient with heart ailments in the emergency. So they don't have to rush to that, the far away, the NH main center. They are having the small units where they can treat the patients, and that the doctor may come there to do the surgeries even. So these cost centers, different cost centers have different inputs, and we need to understand which are those inputs and how they are playing a role in that. The fourth can be full cost of each input. After identifying these inputs, we have to understand that full cost of each input, that for each input how much cost I am incurring. Can I reduce that cost with keeping the input same, improving the technology, or can I do a better mix of these inputs? So I need to understand that what is the full cost contribution by each particular input, and which can also be the contribution margin per unit, right? That the variable cost by particular unit for a particular factors of production and its difference from the selling cost, and it shall not go down. Then I am losing my profit. My contribution margin shall not go down by a large margin. The next one is allocate all costs to final cost centers. So all costs, allocate all costs to final cost centers. That means all input cost is coming to the final cost centers. After I assign the inputs, I get the full cost. After I get the full cost, I allocate all costs to the final cost centers, and then I can compute the unit cost, which is the average cost or marginal cost, the unit cost for each final cost center. So I will compute the unit cost for each final cost centers. Yes, that is, ICU may have different services, ICU may have different inputs, and After understanding cost contribution by each input for each cases, I will estimate the total cost for this cost center, and then for this ICU 1, ICU 2, ICU 3, I can probably or NICU, ICU, NICU, SICU, special intensive care unit, neonatal intensive care unit, I can estimate my total intensive care unit cost. And then the final one is, then you get the results of your entire cost estimation. And this is how you do a cost estimation for a particular hospital services, and this is eventually is not a very easy one. You can download a document which is given by which is a manual for hospital managers, analysis of, I will just write it down, it's known as analysis of hospital costs. Analysis of hospital costs, a manual for managers. Yeah, and this is a document published by World Health Organization in 2000. You can go through this, and you can get several articles by NCBI or by BMJ who have estimated or tried to estimate the cost functions in hospital. Thank you very much.